over the years, we get lots of inquiries or questions from people from around the globe, so keep them coming. I've never done a video ever on Costen syndrome, so we're doing this because we've had several inquiries about this syndrome. Dr. Costen, back in the day, a doctor would see some patients, write up the case histories, and then it's common in medicine then to name the syndrome after the person. So Dr. Costen first reported it in 1934, and what he was trying to do was try to figure out why people had these neurologic symptoms and how it could relate to the mouth. And the most common things associated with Costen syndrome is that the people have various noises in their ear. It could be humming, could be ringing in the ear, could be crackling, could be ear fullness, could be decreased hearing, different sounds. Like I've had people come swishing sounds, humming sounds, high-pitched sounds, low-pitched sounds, vibratory sounds, vibration. So in other words, how to try to explain it where it's actually coming from malocclusion or the mouth. And we all know people who they get on a mouth guard and they feel much better. But likewise, I see people who they put in a mouth guard and it makes them worse. Like we had one gal, Danielle was up in Chicago at the time at the office there when we used to have that office. Then she showed me a video of a young lady with Ehlers-Danlos syndrome who put a mouth guard in, that was just made by a dentist. And all of a sudden, man, her cerebellar function, her balance got terrible. And she was walking this way, that way. She had no coordination just from the mouth guard. So I'm going to explain as best as I can, and it's almost like philosophical, of why I believe that the major problem with people, it's the neck, it's not the mouth. So I know the mouth, and trust me, having been early in my career, I saw so many dentists, had my teeth shaven down, had a myriad of splints. So so I've been a patient, early in my career and spent a lot of money on various dental things. And in the end, I'm telling you, it's mostly the neck. In other words, Dr. Costen in the dental profession has said that a lot of this stuff, these neurologic things, Meniere's disease, dizziness, ringing in the ears, migraines, it's from malocclusion or the teeth aren't hitting quite right. Where I'm here to tell you that if it's related to the mouth, it's probably related to instability of the jaw, which is TMJ instability, which instability, like if you have clicking, popping, grinding inside your jaw here, the TMJ joint. So in other words, you open and close and there's clicking, popping, grinding. Clicking, popping, grinding in any other joint is what? Instability. So in the TMJ, it's instability. So instability is a ligamentous problem. If you look up autologous blood injection, TMJ, injecting blood as a proliferant in the TMJ, it works really, really good. And Dr. Costen in 1934 described Costen syndrome. Well, look in the Journal of the American Medical Association in 1937, Dr. Schultz in Chicago, who was a colleague of Dr. Hemwall. Dr. Hemwall was born in 1908, so he would have been 29 then, right, practicing in Chicagoland. Dr. Schultz he was a surgeon. He was like a maxillofacial surgeon who did a lot of prolotherapy to TMJs, and he had unbelievable amounts of success. You could find that 1937 article that he wrote. There is a connection between the TMJ and the inner ear, which we'll talk about. So definitely TMJ can cause neurologic problems. I'm just saying, in my opinion, most of the problems are a structural problem of the actual joint or a problem in the cervical spine. And that can cause all kinds of things. So Dr. Costen and the dentists who do this kind of work, and I'm not saying that they can't help a lot of people, I'm just saying in general, the problem is a joint problem, not a malocclusion problem. I have people who have teeth pulled, they have all kinds of stuff done in their mouth, and I would just challenge you that, is it the uneven ground or the uneven bite that you have to address? So in other words, for the person who walks on the beach, that would mean the treatment would be, if anybody has knee problems when they walk on the beach, we got to level all the ground, we got to make it all level. Or if we assess them when they're not on the beach, do they have a functional joint problem? Does the person who has knee pain walking on the beach, do they have knee instability? So you bring them into the office, you do ultrasound, you'd see the knee joints unstable, then you do prolotherapy, then their knee gets stable. Guess what? The unlevel ground on the beach, they can walk on it fine. In other words, you stabilize the knee, then they can walk up and down the beach no problem. So it's not the unlevel ground on the beach. So you do prolotherapy in their joint. It may affect their bite somewhat, but they're still going to have like malocclusion or da-da-da, and they live their life 10 years, 20 years, and they don't have any problems. The dizziness, like it. So in other words, in our office, we assess the TMJs, but we also assess the neck. And if they have a neck instability, and I'm going to explain a little bit about how that can affect the TMJ and the hyoid bone and all kinds of things. But if we get their neck structure good, we get the alignment as good as we can, we do prolotherapy to tighten the ligaments. Then if they have instability of the jaw, because it's a neighboring joint, it's connected, then we stabilize that joint. Guess what? Their symptoms go away, right? The hearing improves, stuffiness in the ears improves, ringing goes down or hopefully goes away, occipital pain, tongue pain, weird sensations in the tongue, stuffy nose goes away, vision improves. And I'm telling you, the occlusion, they still have malocclusion, but all the symptoms go away. So that's, or they get help. So that's been my experience. That's why we emphasize a lot more the joints, like the TMJ and the cervical joint. So these are the many mechanisms by which TMJ problems can cause neurologic symptoms. So in other words, when you have TMJ instability, then it can cause face and neck muscle tension, right? So any muscle that attaches to a joint, when there's joint instability, those muscles can get tense. Now, normally with TMJ, they would say that, no, you have bruxism, and bruxism does exist. So bruxism just means that during the night, the person's clenching. And you know that you're clenching because your canine, we're all supposed to have canine. So if you're a canine tooth, your canine teeth are the same level as the rest of the teeth, then you know that you're clenching at night. The most common reason that a person's clenching at night, in my experience, isn't malocclusion, it isn't TMJ, it's just that they feel stress. They just feel stress. Because peaceful people, when you go to bed, you sleep. So we talk about in the office, and again, it doesn't mean that they have necessarily a lot of external stressors. You could just be watching the news, right? So anybody who watches the news before bed, that's a bad thing to do because it's stressful, right? So before bed, what we all should be doing is making sure that we have really positive thoughts, whether that's reading a book that's positive like the Bible, or praying, like parents who pray with their kids right before bed. That's a great thing to do. Listen to really calming music, Pachelbel, Andrea Bocelli. Then there's certain preachers that I like that I get a lot out of, so I listen to them often. That's what I did last night in preparation for this, and I just slept so good. So good because, in other words, right before bed, you have really positive thoughts. So what's going to happen to your body if you're going to bed and you feel stressed for whatever reason, right? You're on your cell phone and you're going through Facebook and there's just all this stressful stuff. Obviously, one of the things that can happen is you have bruxism. So if you have bruxism, do you think bruxism, clenching at night, is that going to stress your TMJ? Is that a malocclusion thing? Or it's like, no, you got the body's doing that all day and it's causing instability in your jaw. So to resolve it, you have to get prolotherapy in your TMJ joint, but also you got to sleep good. So in the office, we help people to do that. Obviously, the forward head posture. So I'm going to get out Ed. Everybody knows Ed. See the hyoid bone here? The hyoid bone right there. So if we look at Ed, we have the head, we have the TMJ, right? This is the TMJ. Then you have, look at how close with Ed, this is the styloid bone, how close the C1 is to the TMJ. Can you see how close that is? So forward head posture can give you cranial nerve dysfunction or dysautonomia. Forward head posture, neck tension can cause hyoid bone instability. So the hyoid bone is right here. You can feel it on yourself. The muscles above it are called the suprahyoid muscles. And the tongue muscles, the tongue is a muscle. So the tongue, so if your tongue isn't working quite right, it could be that the hyoid bone, there's problems like the hyoid bone is moving too much and you actually might need prolotherapy to the ligaments that hold the hyoid bone. So what ligaments hold the hyoid bone is the stylohyoid ligament. So if you have forward head posture, so you have forward head posture and the mandible is way out here because of the forward head posture, there's going to be tension in the stylohyoid ligament, So for the first time in history, we're all kind of like this, right? With cell phones or we're typing. So that stretching right here can put a lot of tension on the stylohyoid ligament. The ligament then can get calcified, and that's called Eagles or Ernest syndrome. And eventually, that ligament can compress on the jugular vein. And the best test we do for that is dynamic motion, position, extracranial Doppler. So we do that in the office here. Sometimes we also we order a CT venogram. So CT venogram can show compression of the jugular vein by the styloid or the C1, the lateral mass, and that gives a condition called intracranial hypertension. You can get all kinds of neurologic symptoms from that. So that's kind of what down here you get calcification of that styloid. Now, Costen syndrome is more how does the TMJ relate to the ear? Well, it turns out histologically, Dr. Costen didn't know this, but since he wrote his manuscript on the association between the jaw malocclusion and the inner ear, they found out that there's a ligament, which they called Pinto's ligament, called the discomalleolar ligament. It's basically connective tissue that goes from the malleus, which is one of the bones in your inner ear, and it connects to the articular capsule of the TMJ. But again, I would say that at some point a person had symptoms, and before that they didn't have symptoms. What would cause excessive tension on a ligament like the Pinto's ligament, which goes from the malleus, the inner ear, to the TMJ, which are very close, right? Your ear's right here and your TMJ's right here. What would cause extra tension on the ligament so it screws up the ear, right? It screws up the ear. I would say it's TMJ instability. It's not malocclusion, it's instability of the TMJ. In other words, the ligament is normally under tension, right? It's normally under tension when you do what? You open. You open. So if you have bruxism, you know, you're doing it a million times, or during the day you're talking, right? People who they talk or they laugh and all of a sudden they get all kinds of neurologic things. I'd say you probably have either TMJ instability or you have cervical instability. Like that's where the bang for the buck's going to go. I would go down that route versus like you're going to level out the bite somehow, or you're going to change the architecture of the jaw. And anybody who's done this is like many-year process, tens of thousands of dollars, where, you know, a few shots of the TMJ here, a few shots of the TMJ there, work on stress. If you have cervical disc structure or cervical instability, obviously work on that. I have this in here just to show there's muscles, like here's some muscles, you know, that the posterior belly of the digastric goes from the base of the head here, so it goes to the base of the head, then it's going on to the hyoid bone, so there's some of the connections there. This just shows you how close, you know, these muscles go to the carotid sheath, and in the carotid sheath is the ganglion of the vagus nerve. That's right at C1. So if you just look at this, there's all kinds of muscular connections between the skull, the cervical spine, the hyoid bone, the jaw, right? Look at that. Like, look at that, the hyoid bone, the jaw. And most of the problem is we're leading, when we move, we're leading with our jaw. We shouldn't lead with our jaw because this is going to cause a lot of tension here, causes stress here, and then you're going to get all kinds of things such as TMJ instability, cervical instability. So we have to be leading with our chest. You lead with your chest, and your jaw should be closer to your chest. Your jaw shouldn't be way far away from the chest. It should be close to the chest. And we got to get away from looking down at cell phones. So if you want to look down at your cell phone, you should get prism glasses, or you should lay on your belly and look at your cell phone, you know, laying on your belly. And we got to get the back of our neck stronger. So this is basically what happens. You could see as we lead with our chest, right, it's crazy. Scapula gets protracted, you get tension of the sternocleidomastoid muscle, the suprahyoid muscles are in all kinds of tension. You end up getting hyoid instability, TMJ instability, cervical instability. So if we all are responsible with our posture, right before bed, like let's just do things that are positive, that are truthful, that are encouraging, such as listening to somebody who's encouraging. Don't watch the news, listen to calming music, have positive thoughts, maybe tell the God that wanted you created that you love him, and your children, your spouse, your significant other, tell them that you love them. And sometimes it's good just to say something positive to yourself, like, you know, I was a good mother today, you know, I was a good father today, I was a good husband, I was a good significant other, I was a good doctor, you know, and just have that positive thought as you go to bed. And probably, you know, you're not going to clench during the night, right? And then get a good night's sleep. That, of course, helps your body heal. And then if you do have cervical disc structure, TMJ instability, you know, get an evaluation for prolotherapy, curve correction. And once the ligaments get tight, there's stability in the TMJ, stability in the neck, then what normally happens is ear fullness, ringing in the ears, migraine headaches, tongue symptoms, things like that, the neurologic symptoms that Dr. Costen wrote about, you know, they resolve.